and they are the ones who provide both primary and secondary levels of healthcare to all the members of the family and be the first line of contact with the family for healthcare. So, the topic for the first session is managing uncertainty in family medicine.
Chairperson for this session is Dr. Aman Kumar, President AFPI and Specialist Board of Governor in Family Medicine, Delhi. He was recently featured on the cover of The Lancet as Global Primary Healthcare Leader. He is the founding president of AFPI. He is editor-in-chief of the Journal of Family Medicine and Primary Care. He has received the Healthcare Leadership Award 2012 India and Montegut Global Scholar Award in 2013 by the American Board of Family Medicine and Healthcare Leadership Award Dhaka 2020. He has published more than 100 research papers across national and international journal. Then next chairperson for this session is Dr. Mohan Gubendra. His consultant family medicine and directors of Spandana Healthcare, National Vice President of Academy of Family Physicians of India. He has served the armed forces for 22 years, where he was the Deputy Director of Medical Services on Foreign Deputation, Director and Chief Instructor at AMC Center and College. He then took voluntary retirement to provide quality healthcare at the community level. He is the founder director of Spandana Healthcare. He is the founder president of Academy of Family Physicians of India, Karnataka chapter. He has received AFPI National Award 2022, Nama Bengaluru Foundation, COVID Warrior Award at 2021.
The speaker for the section is Dr. Sunil Abraham. He did his MBBS from Calicut Medical College. He worked in a rural mission hospital in central India, which exposed him to the need of a generalist specialist for India. Later, he joined DNB Family Medicine at Christian Fellowship Hospital, Odanchitram. Later, he worked in a tribal mission hospital in Anakatti and later joined CMC Vellore. He did his FRCGP at Melbourne. Currently, he is an expert committee of the MCI for family medicine and he is also in NBE.
Welcome, Dr. Sunil. Please welcome him. He needs no further introduction. And family medicine, managing uncertainty is a very, very important topic. We see undifferentiated patients in our day-to-day lives. Mostly when they reach up to tertiary care, the diagnosis is almost confirmed. So at medical colleges, when we see patients, it's all confirmed, labeled patients. But when they come to family practitioner, first care providers practice, they are not diagnosed. It's an undifferentiated syndromic approach we have to take. And who better than Professor Sunil Abraham can introduce this subject to us?
Thanks, Dr. Rahman. Good morning, everyone. Oh, come on. Good morning. Okay. Usually we tell our patients to exercise, and I think we doctors hardly exercise, no? But last night I saw a video of a lot of aerobic exercise happening after the dinner. I think many of you were dancing or whatever. Anyway, when I talk about uncertainty, I'm not going to talk about uncertainty.
Sunil, sorry to interrupt. I think we have Dr. Kamlesh Bhargava joining from Canada as a chairperson. Dr. Kamlesh, are you there? I just saw his...
Good morning, Dr. Kamlesh.
Just give him a round of applause. He has joined all the way from Canada.
Okay, thank you. So, I'm not going to talk about uncertainty as a career. Last week I had a call from someone who is doing family medicine, and she was pouring out her woes. There is no training, no sessions. We are treated as fill in the blanks. That is a reality. There is uncertainty. I was talking to somebody else who is coordinator for family medicine training, and she said, sir, they are not allowing me to put the postings properly. They are forcing me to do things, etc. But that's not what I'm going to talk about today. I would like to talk about three things. The reality of uncertainty in your everyday family practice, and why that happens, and how do you respond to that. I'll talk about 5 patients who came with upper back pain to me. This is just like a foundation. But how in family medicine, symptoms can be very challenging. Now, upper backache is a very vague, common symptom. No? People come with upper backache. And these are all actual patients which came to a practice. So first was a 75-year-old lady. She said, I got upper backache for a few months. And the red flags were, of course, her age. And she said sleep is affected. She's got loss of weight. Now that's a concern. 75-year-old lady. So there was tenderness of the thoracic spine. Her ESR was high. Asked for an MRI because it had to be done. It showed discitis. So I sent to spine surgery. They diagnosed it to be TB spine. She was given ATT. She was on a brace. ATT is over. She's doing well now. There's some stiffness for some time, but with antitubercular stiffness, she is recovered. There was another man in his 50s. He has been having upper backache for 2 years. And he came to our clinic saying it's worsened for the past few days. So he was seen 2 days before, treated as musculoskeletal pain, and he said, last night I couldn't sleep because severe pain. Now, when I took more history, he says, I get upper back pain and pain on the back of my neck on walking. Now, that is a sign that, hey, this is something else. Took an ECG, showed STT changes, referred him to to cardiac emergency. He had triple vessel disease, ischemic heart disease, presenting as upper backache. There's another lady in her 60s, again upper backache for a few months, sleep disturbed, localized tenderness, mild scoliosis, MRI spine was normal. So I said, oh, this looks like, musculoskeletal pain, but I was wrong. They went somewhere else, had a gallbladder calculus. And she developed cholangitis, and they came to us saying, sir, this is a problem, please refer us to the main hospital. So she was referred. So again, back pain due to gallbladder calculus, worsening to become cholangitis. There was another man, 60s, upper back pain, right infrascapular area, chest, spine, nothing. But because age, it's been going on, he's bothered. He said, painkillers are not helping. Chest X-ray showed infiltrates. And ultrasound showed enlarged liver with Mets. He was dead in 2 weeks after I saw him. Again, just the same symptom. 25-year-old lady with upper back pain for a few months, came with a young husband, no red flags. There was a localized knot, you get a tight piece of. So treated with local steroids, steroid and local anesthetic injection, advised stretches, the pain is better. Patients come with vague symptoms in family medicine. So uncertainty is a certainty in family practice. I worked for a short time in cardiology after my DNB because my wife's delivery had to go to Kerala. And you sit in the cardiology OPD, and it is exciting doing thrombolysis. And I remember patient had ventricular fibrillation. You shock the patient 5 times, patient comes out. It's exciting. But you sit in the OP, you know what is going to come next. It's either ischemic heart disease, severe hypertension, cardiac failure, arrhythmia, cardiomyopathy. 5 or 6 things. It gets boring after some time, because it's so predictable. But family medicine, man, you don't know what's going to come next. You have no idea, right? So why is this uncertainty? We must know our role as family physicians. I would request all PGs to understand this, and others also. So they did a study in the US. They followed up 1,000 people in the community. About 800 has some symptoms. We all get in the morning some scratch here, headache, whatever. About 327 considered seeking medical care. 217 visited a physician's office, of which 113 visited a primary care physician's office. 65 visited a complementary or alternative medical care provider. 21 a hospital. 14 home-based care, 13 visited emergency, 8 are hospitalized. Less than 1 is hospitalized in it's missing here, tertiary training hospital. Where does all our MBBS learning happen? Here. And we think This is what medicine is. So, as I say everywhere, we learn everything about mitral stenosis, right? Final year, if you don't know mitral stenosis, you fail your exam. You better know. Mid-diastolic murmur with the pre-systolic accentuation at the height of inspiration, left lateral position. If you don't know this, man, and you start working, what is the patient say? Sir, I am feeling tired. What? Who took a class on approach to tiredness? I don't feel well today. What do you mean? You are struggling. I got aches and pains. The word kai kal kodachil, it's banned in our department. We don't use that word, because we don't know what is happening. We don't learn that because our learning happens here, where is much more certain. So what's the difference? We are not seeing referred patients in a tertiary teaching hospital in family medicine. We are not seeing that. We are seeing patients in a different context. So what's the difference between family practice and tertiary hospital? They come early in the disease. By the time they reach the hospital, it is progressed. And it is very clear. But here they come very early. They come with upper backache, ischemic heart disease. They don't, by the time they take cardiology, it is evolved MI. It's easier. They come with mild, vague symptoms. Elderly person, 2 days slightly off, urinary tract infection. But by the time they come to casualty, it's well established. They come with non-specific features. Well, in main hospital, there is well established. We see undifferentiated patients, but they are seen in subspecialty. And subspecialty is a reality now. But we see what we call the undifferentiated patient. The pre-diagnostic probability is different in family medicine and in a tertiary hospital. If somebody comes to ortho OP with a shoulder pain, 60-year-old person is probably, supraspinous tendinosis, rotator cuff injury, periarthritis, shoulder, maybe malignancy, which is not that common, etc. They come to family practice, it could be anything. I had a 60-year-old lady who said, I got shoulder pain right-sided shoulder pain for 2 weeks. So took the history. He said, the pain comes when I am walking. When I rest, pain goes away. Along with my pain, I get palpitation, sweating, tiredness. Has not gone to ortho, has come to family medicine. ECG showed T inversion, put on beta blocker, whatever, pain disappeared. They come with undifferentiated symptoms. So we need to be very, very alert. And again, our patients can be any age, any tissue, any organ, any gender. I'm sad to say this, but I have to say this. One of my patients who, when I checked the previous record, it was written that she had a small fullness in the right adnexa. So ovarian, some fullness, 4.5 centimeter ovary. So it had to be followed up. So I referred to the main hospital. Now, obstetrics and gynecology, I think now there are 5 or 6 units. Each is subspecialized, okay. She said, I went to one unit, came back, because the doctor told me, I only see uterus. Why is an ovary coming to me? This is reality. She said, sir, I felt so bad. She said, I don't see uterus. I don't see ovaries. I see only uterus. Our for us, it can be anything. Anything. And we have to be alert. So we do what is called there's a uterus doctor. We have the biopsychosocial model of health. Because we don't look at patients as tissues. We don't look at patients as, an organ or whatever. We look them at as people. I had a patient whose diabetes was not controlled. So I asked her, what happened? Because she is poor, she's getting subsidized medicine. You have the medicines with you. Sir, my husband has not worked for 2 days. I haven't eaten. How can I take the tablet if I don't eat my food? That is family practice. Because we are not looking only at, you have the medicines, what is your HbA1c? I had patients coming and say, sir, they only look at the blood level and give medicines. I want a doctor who will talk to me, who will examine me, who will hear me. That is family medicine. Because our model of care is this. So, but other models, I'm sorry to say, we are becoming more and more masters of techniques, technology, disease, ologists for everything, strokeologists or whatever. So the reality of the vague in daily practice, what do you do about it? Accept it, address it. It is a reality. If you want to become absolutely 100%, I need a tissue diagnosis, don't do family medicine. Because uncertainty is a reality. The subspecialist will want to dig deeper. Now, is that needed? Absolutely needed for some patients. I'm not degrading them. We need some places where you have to go dig deeper and find out what is going on there. Like the Reyes syndrome sir was telling about the tumor which was causing the pain. We need people who do that. But in family medicine, it is different. So we send patients with abdomen pain or headache to multiple departments, nil opthal, nil gynae, whatever. So what they're saying is, in my specialty, nothing is wrong. I don't know what your problem is. That is not my problem. But in family medicine, it is, I understand you have a problem. Let's work together to find out. That is how we approach our patients. Often no fine diagnosis. The diagnosis could be, okay, shoulder pain for evaluation. I don't know what's going on, but shoulder pain for evaluation, that's a diagnosis. And we work on that. And as I said, no kaikal got a chip, So how do we manage uncertainty? It is a challenge for the physician and the patient. Because as family doctors, we have to tell, oh my goodness, what do I do? I don't know what's going on. And we have to tell the patient also, I'm sorry, but I don't know. Doctors don't want to say that, no? That we don't know. But we have to accept it, that this is a reality. So what do we do it? Get used to it. We are generalists. We are generalists. We see the big picture and the connections and not just the individual parts. Reductionists would say, take one subject, go deep, 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 learn everything about it. Generalists would say, we see broad. How are these connected? How is the job of a person connected to his backache, connected to his lifestyle, connected to the management? How is the fact that the husband is sick, no food to eat, wife hasn't eaten, uncontrolled sugars? We see the connections. So we had a visiting specialist in CMC who was a pediatric nephrologist for the distal tubule. That's how it has come. But we are generalists, and be proud of that, because the world needs generalists. Any big organization cannot function without generalists. It's a reality. Because the single subject reductionist, they will do well when everything is going on well. If something goes this way, that way, they will not be able to handle it. But we thrive on uncertainty, and look at the big picture, and we are flexible. So how do we manage this? Be excellent clinicians. History, physical is important in the age of PET scan, SPECT scan, or whatever. 75%, as somebody said, of your diagnosis comes from history. I think William Osler said, listen to your patient, he's telling the diagnosis. There is no shortcut for that. And I was telling somebody, there have been studies done. When we have medical students coming for family medicine rotation, we tell them, if you ask the patient what is wrong with you, and you keep on asking what else, How long will they talk? This is 5 minutes, 10 minutes. Okay, let's try. It's usually 30 seconds, 40 seconds. Research has shown 1 to 2 minutes. If you interrupt them, it will take longer. Because the patient is an expert about his health. And the patient comes with, I got these problems, I'm worried about these things, what is going on, and come and say, doctor, I got chest pain. Then you go to your MBBS mode, no. What is the site? And you, what exercise? We want the list. We want to ask all those things. And he says, no, wait. I want to know, do you have this or not? But you just keep quiet. Tell me more about it. What else? What else? And then there is leading questions you ask. But you get your diagnosis. So excellent. Be excellent in your history and physical. This is the most important investigative tool that we have. Your hands, your eyes. Listen, very, very important. Look, listen, feel. I tell students, look into the eyes of the patient. What is going on in this patient? Once we are having rounds with medical students, there was a 70-year-old man who was obviously depressed, admitted for not eating well for past few months. He was looking depressed. I told the students, look into the eyes of the patient. So they took a torch. Sir, what is it? Carefree, huh? What is happening? I said, no. You look into the eyes. We miss that, right? And this is not helping. We have forgotten how to look into eyes of people. We look into the screen. Gives a lot of information. You look for cues. You look at the patient's facial expression. It will tell you something else is going on. So these are skills that we need to develop as family doctors. Pattern recognition. See, there are different ways of clinical reasoning. If a patient is admitted in an ICU with fever or maybe in shock, you do an exhaustive search. What is the cause of this? And that's needed. You can have algorithms for diagnosing problems. But in family practice, most of our diagnosis is through heuristic or pattern recognition. And you look at the patient and say, hey, this reminds me of something I've seen earlier. There was a 60-year-old lady who came with dysphagia. 60-year-old dysphagia, what is it you're worried about? Malignancy, Sent for upper GA-scopy. Came back, GA-scopy, no malignancy, but esophagus covered with candidiasis. So sent for HIV and diabetes, negative. So what's going on? With the, started treatment for candidiasis, but looked at her face, it looked hypothyroid. TSH was 150, started on thyroxine, dysphagia disappeared. Where do you get that skill? Look at patients. Recognize patterns. Now, those of you are complaining there are too many patients. Each patient is a teacher. Learn from them, because these patterns you learn over years. I mean, I'm learning even now. 2 days ago, there was a patient. I learned something. You keep on learning from patients, So recognize that let's say you're seeing 40 patients a day. I see about 40 patients a day, 5 in an hour. So you don't have a time to go through an algorithm for every patient. And that is also a waste of time. And you will start doing investigations, etc. for multiple things. But when you look for patterns, this age group, in my community, if somebody is coming, what is the most probable diagnosis? You think like that. No? Train your mind to recognize patterns. The other thing is to use time as a diagnostic tool. When there are no red flags, you got something vague, okay, let's wait. Patient is not losing, no red flags. And I think someone said in Raquel's textbook is written, 25% of symptoms in family practice disappear without any intervention. They might just go off. We all get symptoms. Now you get some twitching here and you go, oh, what's happening? After a few days it goes off. But if you say, oh, let's do a EMG, let's do an MRI. No, you can wait. You can wait, use time as a diagnostic, and of course you need a safety net and you need to follow up. Work on the doctor-patient relationship. This is very important. Tell the patient, look, I don't know what's going on, but this is my plan. These are the possibilities. We can wait for a week. For example, people coming with dyspepsia, not with no red flags, can we wait? And patients are also happy. But safety netting, come back if these are there, and have a clear plan. Rethink, read, research on your diagnosis. Last week one professor of hematology in CMC Ludhiana was telling, if my juniors don't look at PubMed at least once a day, they are not up to date. Find out what is current and keep on learning. And if you have a difficult issue, read about it. Rethink on your diagnosis. What is going on? Try to find out. Discuss with a colleague. Very helpful, because no one knows everything, right? You have to talk. And then I love this safe diagnostic strategy, because people come early. We need to have a safe diagnostic strategy in the midst of these uncertainties. And I always back for John Murtag's textbook of general practice and his diagnostic strategy, which is very useful. But remember that common things are common. However, we cannot miss the dangerous conditions, which come very early. I need to have a high index of suspicion. So this acronym for a safe diagnosis strategy is very simple, but very useful. One is think, what is a probability diagnosis? Like that lady who came with shoulder pain. 60-year-old lady, you think about musculoskeletal. 2 years ago, if somebody came with fever, cough, mild shortness of breath, you will think of COVID. Because in the current scenario, in your community, if there was a lot of COVID, but now if somebody comes with fever, cough and shortness of breath, you don't think of COVID as a first probability diagnosis. So you should know, okay, based on the patient, based on your community, based on what is happening there, what is the probability diagnosis? The second thing is red flags. What serious disorders must not be missed? Is there a red flag here? Could this be something more serious? And you burn your fingers. I had a lady who came with dizziness. You see, so many dizziness can make you feel dizzy. But she had a tumor, which she found out later. I missed it because I didn't check her fundus. I didn't look for sensation of the cornea. But thankfully it was picked up early and she's fine. But are there red flags that I should not miss? What are the things that you can be overlooked? For example, somebody coming with foot pain, there is something called the Ottawa rule, which guidelines on whom to take an X-ray. Not all patients with foot pain need X-ray. But there are guidelines. And if I don't take an X-ray, I can miss it. So are we overlooking? For somebody coming with palpitation, I had a patient with palpitation. She was a bit anxious, but she said, in the past 4 days, I'm drinking a lot of coffee. So if I had missed that history, I can give treatment for palpitation, but she'll continue to have it because she was anxious. Now, she was anxious because she was having chest pain. She was anxious because having chest pain because her husband died 7 months ago because of myocardial infarction. That's the background. But that history of having caffeine is also important. The fourth one, what we call masquerades or mask in family practice. So there are 7 primary masquerades. Depression, very common, very common. A study in our department done by mental health department, they looked at women 15 to 45 years old, 50% had a mental health problem, 50%. They have not come to a psychiatrist, they have come to family medicine. Many of your patients will have mental health problems and they will not come and say, I'm depressed. They will not come and say, I have a mental problem. They'll come and say, I got aches and pains, I'm tired, etc., etc. Patients who come and say, I got a small turn, I feel a little bit. This is very common in my practice. Daytime I'm feeling a bit dizzy for 1 second, and then it was okay. No other red flags. Why? 1 month I have not been sleeping. Why? Stress in the family. Asking about sleep gives a lot of clue. Mental health, depression is very common. So learn about depression management. And family physicians are ideal to manage mental problem, as we heard yesterday. Diabetes doesn't present with polyuria, polydipsia, polyphagia. Rarely presents like that. Can present with loss of weight, feeling tired, infections like candidiasis or whatever. So diabetes is common. It can present as anything. Drugs, side effects of drugs. I had a lady with nocturia, passing 5 to 6 times. Her daughter brought. So she said, doctor is having passing urine. So this lady had high blood pressure, was put on medications for cataract surgery, had the surgery, BP is well controlled. So creatinine was normal, urine protein creatinine ratio was normal, no features of cardiac failure. Then the daughter is telling me, sir, she was put on amlodipine. I think amlodipine can cause nocturia. I said, wow, I didn't know this. So I looked up, yes, it can. So I stopped amlodipine, put her on something else. It causes pooling of fluids, and night you can get up to pass urine. Nocturia disappeared. Next time the daughter came and said, sir, my son is in IT, so he found out from Google that amlodipine can cause. So I learned something. So drugs can present. So always look at the list of drugs. Typical thing will be enalapril cough. No? But now we don't put that much away. But enalapril can cause cough. After many months, it can cause cough. Is a drug, that's one of the things to look. Anemia can present as palpitations, dizziness, angina, thyroid disorders, hyper and hypothyroidism, spinal dysfunction. Now, spinal dysfunction is something we don't learn in MBBS. I'll tell you what it is. See, when you have a problem in the spine, you get symptoms along the dermatome. So if you have an upper cervical problem, it can present as headache here or tingling numbness. If you have you can have a cervicogenic shoulder pain. You do the Sperling's test when you extend and press. Or you can present as chest pain. You can have thoracic spinal dysfunction presenting as abdomen pain. This is not very uncommon. And the treatment is not analgesics, but posture, etc. So we had to find out from the history. Again, history is very important. Is it spinal dysfunction? And UTI, elderly and children. So this is a safe diagnostic strategy. The last one is the patient trying to tell me something? What is the real agenda? I had a 21-year-old lady brought by her father saying, sir, check her sugars. I said, why? No, check her sugars. So I was going to do, and I asked, I realized there's something else going on. I said, what's happening? Sir, 3 marriage proposals for her got blocked by her relatives. And she's a little bit not eating well, feeling tired. So please check her sugars. So I said, look, the answer to that is not checking sugars. Maybe you had to talk to your relatives and resolve a conflict. The next day the girl came after the test. She came in smiling. Sugars were normal. And the real reason was this. Patients might come because they are struggling and it's a cry for help. A poor patient might come because they don't have money to buy. They're struggling, they're being given expensive drugs and they're scared. So we have to know what is the real agenda. So family physicians are masters of uncertainty, I would put it that way, and be ready to face it. And the safe diagnostic strategy is one way to assess it. But also, as I said, be frank with the patient, build the relationship, but be good clinicians. Take good history, good physical, make sure that you're not missing anything. So I put this as masters of uncertainty. When these people started the conference, they said only 50 people and they persisted. I congratulate them. Well done. Thank you. I'm happy to take any questions if you have.
Hello. Thanks, Dr. Sunil. It's always a pleasure listening to Dr. Sunil Abraham. So very nice narration. Before, I think you have a question, sir. I'll just give me 2 minutes. So first thing is to accept the fact that there is uncertainty in practice. Don't expect that every patient visits you, you will have a diagnosis. That's the first thing. So rightly said, uncertainty is certain in family practice. And as rightly brought out, I think we should rely on our clinical acumen and listen to the patients, look at the eyes. These are very good tips Dr. Sunil has given. One thing I just want to ask you, like, to get over this uncertainty in the initial years of practice, probably over the years by experience, you'll be able to pick up looking at the eyes and by your own experience what the patient is trying to tell. But is it not a good idea to practice evidence-based medicine and have care pathways in the other thing? That gives a kind of confidence. Of course, you cannot go through those algorithm every time you have a patient, but maybe once you have a patient with undifferentiated this thing, maybe go back and look at these algorithms and be well versed with that. And does that not help in your presentation? You said you
Absolutely. It's like learning how to drive. You know, when you start driving, they say, if you're turning right, pause, look to the right, make sure there's nothing, and you turn. And you go in your mind these steps. And after some time, that becomes part of your thinking. You know, after driving for some time, you don't say pause, look to the right. No, you just do it. So that initial learning is absolutely very important. Yeah.
yes, sir.
My pointing is the medico-legal aspects. Is there any that problem you face? Because it is uncertainty, and we go with presumptive diagnosis and treatment, do's and do, either commission or omission. What? Because now we are all. It is a defense practice. We have to not only taking the patient care, we have to know what are the legal implications in that. Because unfortunately it is made as a healthcare industry. Because of that industry name has come, all the rules and regulations applied for the industry has come into the service profession also. Please kindly, did you face any difficulties on that angle, or it is only a myth, there is no real problem in this way of practice? Yeah.
I think, sir, I should explain that I'm talking from the family practice setting. So if I see 40 patients a day, about 25 to 30 will be my repeat patients. Patients whom I have known for years. And I know what is the kind of disease they have. Problems with uncertainties will be very few in a day. Many of them are otherwise healthy. They have come for their repeat medicines to have a chat. You know, they come, okay, how are you, doctor? How is your daughter? How is your father? You know, here is chocolate for your daughter. You know, that's what happens. The uncertainties, the safe diagnostic practice strategy really helps. Because you have to think, does this patient need an MRI? You do an MRI, absolutely. But it should be based on your clinical reasoning. Like that lady who came with upper backache, she needed an MRI. If I had left her saying, no, this is okay, it would have been a disaster, you know. So, depending on the situation, like we had a lady this Wednesday, came with, she's a 53-year-old lady, non-SLE patient, has come with pain of the right knee for the past 1 week. She had a small trip and fall a week ago, then after that she was walking, now 2 days the pain is increased. She came, she's got fullness of the knee, she's got local warmth, movements restricted. So I told my junior doctor, look, this could be septic arthritis. Sent to casualty, period. Then it could be an emergency. They went, they took an X-ray, they suspected fracture. CRP was normal, counts were normal, so rules of septic arthritis. They did a CT reconstruction of the knee. There was no fracture. It was only an inflammation, soft tissue injury. But at that point, I don't say, this is uncertain, let us wait. No. You know. Exactly. So that's why you have to be very, very sharp, have a high index of suspicion.
But sir, the medical-legal aspects in general practice is very less compared to the hospital settings. But however, notwithstanding that, as the practitioners, I think we need to practice two things. One is communication and documentation. That has to be done, irrespective of the nature of the case you're seeing. So that will absolve you from any
Thank you very
legal.
much. I don't know, Doctor, am I audible?
Yes, Dr.
Yes, yes,
Kamalesh.
Yes, wonderful session, Dr. Sunil Abraham. And I think it should be recorded and be given to every medical school. And they should know how to handle uncertainty. Two things maybe which I would like to point out. One is about this medical legal aspect. Always think the doctors, when they are doing a consultation, they should think of red flags and also instruct the patient, if something untoward happens, please contact me and or their office so that they are covered. Because many a times the outcomes will be different. So that's the way to handle the medical legal aspects. That's what I think. The second is, maybe I heard or did you address the issue of using time as a tool to make a diagnosis?
Yes, sir.
These are the 2 points which I want to make. Thank you.
Thank you, Dr.
Thank you,
Kamalesh.
Dr. Kamlesh. Any more questions?
One thing I would like to tell all the juniors here practicing, I completely agree with Sunil Abraham saying that we do an experience practice and also with Mohan, because evidence-based is also very important. Just a small example, if a patient comes to you with simple anemia, you look at them, she's pale, and you ask the history, and you think she's got bad periods and all that, you definitely come to a clinical diagnosis of iron deficiency or something like that. You will start her on iron? Will you start her on iron? Won't you want to look at something else that could help her? That is a place where, like Mohan said, a simple blood count you can do on her. Okay? And if you look at her MCV and it shows something like 107, then you can, maybe you have asked her a question or whether she's a vegetarian or something like that. And if you look at that MCV and it shows 107, you can then think it is a macrocytic anemia. Though she looked very pale and she said the periods were all like that, she could have a dimorphic anemia or she could have a megaloblastic anemia pure. So that is where the experience and the evidence, you understand? The other thing about this medical legal issue of doing the general practice, if you see a bad patient with chest pain and you know she's dyspneic and she needs admission but not willing for admission, please don't prescribe any tablets to her. Please write, please get admitted and do that. Because if you give some tablets, she goes home and she dies and somebody complains, then they say, this doctor said, take these medicines, you will be okay. We have no evidence to prove that we have told them to get admitted. Even if you write it in their card, they take the card with them and then they never show us that card. So this is the second advice I want to give you. If somebody is very bad and needs admission, please don't prescribe medicines for that disease. Maybe one dolo you can write and then send her, not even a dolo actually. I don't write anything, I tell them, please get admitted. Otherwise you may go to any other center to get treated, because that is a place where the medical legal aspect can hit back at you. You give some medicines and that, because I had an experience like that. One patient came to me and then the next month a policeman came to see me, because this patient is absconding. And then they found from records that they had visited me. That's a time when I thought she looked very depressed and she had come with one of her friends, and that was the obvious reason why she absconded. And then we don't hold on to our records actually in our hospital, but something made me take a Xerox of what I had written, because she was not willing for whatever I said. So that is a way I could save myself. So small things in your general practice where nobody else will come to your help, you know. If you work in an institution, at least the institution has a vicarious responsibility. The chairman of the institution will help you, the IMA will, so many things. But when you sit in a clinic, be extra careful about small practices. Thank you, sir.
Yeah, I think it also depends on your context, you know. Like if you are in a remote place and patient is anemic and you know there is a lot of anemia there, and the most probable cause is iron deficiency because of bad nutrition, you treat with iron. I think, again, even with the ischemic heart disease, patient is come with a blood pressure, high blood pressure, definite history of angina. ECG shows some T inversion, and patient says, look, I can't go to the hospital because my elder mother is alone at home. And I personally would start treating. And because otherwise I feel I am responsible if that patient walks out and dies. You know. So, but document very clearly, explained these other things, document and keep it. I don't think any court will pull me up for that. But there is, I feel, a duty of care. You can vary on that. But I personally would start. I have done that. A patient came with cardiac failure, said, sorry, I am not going to the hospital. You start the treatment. Clinically had all features of cardiac failure, elevated JVP, pedal edema, I know, your apex is shifted, etc. Yes, Malini, yeah.
Documentation, I think, is something that we often forget to stress, and we often tend to sort of shelve to later or shelve and become very, very careless about. So if you could just stress a little bit on how to maintain medical records. Ma'am mentioned that some hospitals don't maintain the records, but the record goes with the patient. And naturally, this puts the physician in a very, very vulnerable place.
Yeah.
So a
I feel,
little
yeah,
bit about
yeah.
medical records.
I think the time has come when all of us should go into electronic medical records. Makes it very simple. All our family medicine clinics are EMR, you know. It makes it very easy, and you have templates that you can use to fill it up. Like, for example, if a child comes with fever, cough, and cold, 2-year-old child, looks like a viral URI, I have a template for recommendation. I just click that. It takes 1 second. Review if the child has these. But is on document now. Easy to go EMR. It makes life so much easier. Initially, it might take a bit difficult typing, but I would strongly recommend go for EMR and document very clearly. Red flags should be documented. Your advice should be documented. You know, your clinical findings should be documented. Like on Monday, one lady came, 45-year-old lady came to our family medicine center with some mild weakness of right upper limb, lower limb. So she came in about 3 hours after the whole thing started. No, I think about 4 hours after, or 3.5 hours after the thing started. She came in, she was walking with a little bit limp. Mild, I think 4/5. So the doctor there called the stroke nurse in the casualty and referred, because 4.5 hours is the time. You know. So from casualty, I got a call. So, you know, this patient was referred without informing anyone. We have lost the window period. I said, look at the records. It's clearly written, informed stroke nurse. No, you should not inform a staff nurse. I said, no, it's written stroke nurse. They had to keep quiet. Of course, her CT was normal, she's fine. It was a TIA. But the documentation was important. Very, very important. Yes, Dr. Raj.
Thank you for saying that you should communicate with the patient. There are many patients that I see who I'm not sure what is going on. So what I tell them is, look, I don't know exactly what's going on, but I cannot find any signs of any danger or red flags. Therefore, we could go this way and do these tests, but they'll be costly and they're unlikely to yield anything. On the other hand, we can wait. And while we wait, if you have any of these red flags, make sure you come back early. Otherwise, come back in 1 month and let's see what's going on. So this communication and informing the patient and respecting them. They may be very poor, they may be uneducated, but when you talk with empathy, they understand. And most of them will say, okay, I will wait because I trust what you're saying. And as long as you document that, and it's not just a document, not just a legal aspect, It is the fact that you care for that patient and you want to do the best for that patient. So communicating and saying, I'm not sure, is not a bad thing for doctors to do.
Thank you.
Thank you. Dr. Raman?
Thank you very much, Dr. Abraham, for this excellent, very important, it's kind of one of the defining topics of family practice. So very useful for the youngsters, PGs. Thank you very much. And we move to the next session now.
Thank you, sir.
Thank you,
I would like to
Dr.
request
Sunil.
Dr. P. Krishnamurthy, sir, to honor the speaker and the chairpersons.
Very nice.
Thank you, sir.